Welcome to the deep dive, where we don't just scratch the surface, we plunge right in.
That's right.
Today, we're tackling something pretty fascinating, maybe even a bit unsettling. It's about AI, specifically large language models, LLMs, that are, well, sweeping into our hospitals and clinics.
Yeah, it's happening fast. We're talking about AI being used for summarizing really complex medical info, helping with diagnoses.
Even creating initial treatment plans. I mean, it's truly transformative stuff.
It absolutely is.
Yeah.
But there's this big challenge that hasn't really been addressed head on.
Okay.
Well, the way we currently evaluate these LLMs, often using things like, medical licensing exams.
Standardized tests, basically.
Exactly. They just don't capture the sheer complexity, the messiness of real-world clinics. Patient language.
Yeah.
It's all over the place. Different styles, structures, quality. It's not neat like an exam question.
That's the core tension, isn't it? So the big question we're really digging into today is, do these subtle, non-clinical language changes, stuff that shouldn't matter, medically affect treatment choices by LLMs?
And crucially, do they affect them the same way they affect human clinicians? That's a huge question, given the stakes.
Absolutely huge. So to help us navigate this, we're diving into a brand new scientific preprint. It's hot off the digital press.
Yeah, it's available on ArcFavor along with its Dataset card. These give us some really robust factual insights into this new research resource they built called MedPerturb.
MedPerturb.
And it's custom built to get right to the heart of this challenge.
All right, let's unpack this then. Today, we're taking you behind the scenes of, well, a pretty fascinating experiment pitting human intuition against AI logic.
We'll peel back the layers, look at how MedPerturb was designed, how it sort of challenges these models.
And how humans and AI reacted to these little linguistic twists. And importantly, what it all means for, reliability, potential bias, AI in actual healthcare.
Ready to dive in?
Let's do it. So let's start with the setup. How exactly did MedPerturb go about testing clinical decision-making?
Okay, so MedPerturb is essentially this new framework. Its main job is to check how both human doctors and these medical LLMs choose treatments when the information they get is presented in different ways.
Different styles, you mean?
Exactly. It systematically introduces these linguistic variations, things that, medically speaking, shouldn't change the diagnosis or treatment.
But they might reveal something about how the models, or even humans, process the information.
Precisely. It might expose how they really handle language, beyond just the medical facts.
And the core material they used was these clinical vignettes. What are those exactly?
Think of them like mini patient stories. Short, fictional cases covering different medical issues, different levels of formality, too.
So some might sound like doctor's notes, others more like a casual email.
Yeah, they tried to mimic that real-world range.
Yeah.
From structured electronic health record notes to maybe a more informal patient question you'd see online.
Okay, so they have these base scenarios, then they started tweaking them, right? Introducing these perturbations. First up was gender.
That's right. They took the text and modified gender attributes, sometimes swapping male for female or vice versa.
Gender swapping.
Yeah, and sometimes just removing gender markers altogether, gender removal.
And the key point here is...
The key point is that, clinically, these changes should not matter for the treatment decision. But we know gender can be a source of bias, both in AI and, unfortunately, in real healthcare disparities.
Right, so it's a known potential weak spot.
It is, so testing it is crucial. They were careful, though. They filtered out cases where gender is inherently clinical, like, ovarian cancer, to make sure the changes were purely linguistic.
That makes sense, ensuring it's truly non-clinical. But given that gender bias is a known issue for AI, were they expecting the LLMs to stumble here, or was it more like, let's see what happens?
I think definitely more of the latter. The hypothesis, or maybe the hope, was that human clinicians would mostly ignore these non-clinical gender cues.
As they should.
As they should. But how the LLMs would react, that was a big unknown. It's exactly this kind of stress test. MedPerturb is for seeing if AI adds variation where humans ideally don't.
Okay. What about the way people talk or write? That's the style perturbations, right? Mimicking realistic variations.
Yeah, so style changes were designed to reflect how patient language can shift. Maybe language associated with certain groups or just less formal situations.
Like what, specifically?
Well, they made some text sound uncertain, adding hedge words like maybe, sort of, or verbs like I think, I suppose.
Okay.
And conversely, they made some text more colorful, adding things like wow, oh, or intensifiers like really, very...
Again, crucially...
Crucially, these only changed the surface language, the tone, not the underlying clinical facts. The patient's actual condition remained the same in the text.
So it's testing sensitivity to tone, almost. And then the third type sounds quite different, format perturbations.
Yeah, this one definitely shifts gears a bit. They took the original vignettes and completely transformed them into two new formats, and they used AI agents GPT-4, actually, to do it.
AI creating the test material for other AIs and humans. Interesting. What were the formats?
First, they simulated multi-turn doctor-patient conversations. So one AI plays the doctor, asks questions based on the vignette.
And another AI plays the patient, responding.
Exactly, creating a dialogue from the original static text. The second format was then taking these generated conversations and having GPT-4 create summaries of them.
Wow. So taking concise info, turning it into a conversation, then summarizing that conversation. It feels like information could easily get lost or maybe de-emphasized along the way.
That was precisely the concern. Could these AI-generated formats, just by changing the presentation, inadvertently hide or downplay important clinical details?
And potentially sway the treatment decision.
Potentially, yes. And this is super relevant because summarization and AI chatbots are being used more and more in clinics.
Okay, so after all these linguistic twists, gender, style, format, what did they ask the participants, the humans and the LLMs, to do?
They were asked 3 simple yes-no triage questions for each scenario. These reflect those immediate decisions doctors often make to manage workload.
The what next
Yeah.
questions.
First, manage. Can the patient just manage this at home? Second, visit. Should the patient actually come in for a clinical visit, clinic, urgent care, emergency?
And third?
Third, resource.
Mm-hmm.
Does the patient need something extra, like labs, tests, imaging, maybe a specialist referral?
Got it. Simple binary choices. And who is making these choices?
On the human side, they recruited independent clinicians, paid them reasonably well, about $60 an hour. They typically took around 5 minutes per case.
And this was recent data.
Very recent,
Mhm.
collected late April to early May 2025. And for the AI side, they evaluated 4 big-name models: GPT-4, Llama 370B, the smaller Llama 3.8B, and a medically focused one, Palmyra Med, the 70B version.
Okay. Now, before we hit the findings, you mentioned this concern about LLM as a judge. Can you unpack that quickly? Why is it an issue here?
Sure. This idea of using LLMs to evaluate other LLMs is getting popular, mostly because getting human experts is, frankly, expensive and time-consuming.
Makes sense from a practical standpoint.
It does, but it's risky. You risk compounding biases. The judging LLM might have its own biases. There's risk of misinterpretation, missing clinical nuances.
So the AI could just be marking its own homework potentially inaccurately?
In a way, yeah. It could distort the assessment, maybe drift away from what human doctors would actually consider sound judgment. MedPerturb tackles this directly by using human judgment as the grounding benchmark.
The human perspective is the anchor.
Exactly. It provides that crucial check against the AI's evaluation.
All right, vital context. So, with that elaborate setup done, let's get to the juicy part, the findings. What did they actually discover? Who agreed with whom and when?
Well, first, looking at inter-rater agreement, basically, how much everyone agreed on the same case. The human clinicians. They only showed moderate agreement among themselves.
Even on the simple original cases.
Even on the baseline vignettes, yeah. Their slice kappa scores a measure of agreement were typically around 0.2 to 0.4, which, isn't terrible, but it's far from perfect consensus. Humans don't always agree on triage.
Okay, that's an important baseline itself. What about when the gender and style changed? Did that affect agreement differently for humans versus AI?
This was pretty surprising. For those gender and style changes, there were no significant differences in the level of agreement between the human group and the LLM group.
Really? So humans and AIs were about as consistent or inconsistent with each other on those?
In terms of the spread of agreement, yes. But, and this is key, the level of agreement was almost always lower for humans.
Ah, okay. So LLMs agreed more with each other than humans agreed with each other.
Exactly. On average, the difference was about 0.12 in slice kappa. Put simply, humans had about a 14% lower consensus rate than the models did, even on these subtle changes.
Okay. Humans are inherently less consistent, perhaps. But you hinted the format changes were where things got really interesting. What happened there?
This is the big reveal. It completely flipped. Human clinicians, they had their highest agreement on the original standard vignettes. Makes sense, right?
Yeah, the cleanest input.
But their agreement plummeted for the summarized contexts. Less than 0.21 slice kappa for summaries. Really low agreement.
Wow. And the LLMs?
The LLMs showed the exact opposite pattern. They had higher agreement when dealing with the summarized context.
Whoa, okay. So humans struggled to agree when the info was summarized by AI, but the AIs found it easier to agree on information summarized by AI.
That's precisely it. Humans found the AI-generated content harder to interpret consistently, while the AIs were more consistent with their own kind of output.
That's a fascinating divergence. So the format clearly messed with human consistency. What about the actual decisions? The average treatment rate, ATR? Did humans and LLMs recommend different things overall?
Oh, absolutely.
Yeah.
Looking at the gender and style changes first, LLMs generally tended to under-recommend self-management.
So less likely to say stay home.
Right. And they tended to over-allocate resources compared to the human clinicians.
More tests, more referrals.
Exactly. On average, clinicians suggested self-management about 37% more often than the LLMs did. Sometimes the LLMs recommended self-management almost 0% of the time, and resource allocation near 100%.
So a much more cautious, resource-intensive approach from the AIs on average.
It definitely seems that way, at least based on these vignettes and questions, a clear difference in their sort of baseline risk tolerance.
Okay. And how did the format changes affect these actual recommendations? Did humans stick to their guns, or did the AI-generated formats sway them?
Dramatically swayed them. Humans were significantly impacted
Yeah.
when they saw the LLM-generated content, the conversations, or the summaries.
Yeah.
They tended to over-recommend self-management, under-recommend actually seeing a doctor, and under-allocate resources compared to when they saw the original vignette.
So the opposite of the LLM's baseline tendency.
Kind of, yeah. For example, those AI summaries led to humans recommending self-management over 30% more often and allocating resources 20% less often.
That's a huge swing just based on how the info is presented
Yeah.
and the LLMs.
The LLMs, in stark contrast, were pretty consistent. Their recommendations for the multi-turn conversations and the summaries look very similar to their recommendations for the original baseline vignettes.
Wow, so human decisions got pushed around by the format while the LLMs barely budged. This must tie into the stability of decisions, the percent change metric you mentioned.
Directly. Clinicians showed much bigger shifts, more volatility in their self-management and resource recommendations when the format changed. About 20% more change compared to the LLMs.
Which really highlights.
It highlights that human clinical judgment seems much more susceptible to being influenced by things like AI-generated summaries or conversations than the LLM's own assessments are. It's like the presentation subtly steers the human interpretation in a way it doesn't steer the AI.
That is fascinating and maybe a little concerning. Okay, let's dig deeper into why these format changes had such a big effect on humans. Was it just that the AI summaries were bad, leaving out key info?
That's the logical first thought, right? But the researchers checked that. They used standard metrics, RG scores, cosine similarity to measure summary quality.
Yeah.
And the summaries were generally pretty good, technically speaking. They captured a lot of the original information. The study found that simple things like summary length or how much it compressed the text didn't really explain the shifts in human decisions.
So it wasn't just about missing information. It was something else.
It seems so. Something perhaps more subtle about how the AI repackaged the information, maybe the narrative flow or what it implicitly emphasized or de-emphasized, that seemed to alter human judgment. It's a really crucial point.
That really is, like how framing affects perception. What about those AI-generated conversations? Did the length of the conversation matter? More back and forth.
Yes, this is another really insightful finding. For the human clinicians, the more turns there were in that simulated conversation,
The longer the chat.
the more likely they were to recommend self-management, the less likely they were to recommend a visit. There was a strong negative correlation, actually.
Interesting. Less likely to send them in if the conversation was longer.
Yeah, and also less likely to allocate resources. The research has suggested maybe longer conversations often had more redundant info, kind of circling back,
Right.
which could maybe subconsciously make the case feel less urgent or less clear-cut to a human reading it.
Okay.
Like if it were serious, they'd get straight to the point.
That makes intuitive sense. And the LLMs, were they sensitive to conversation length?
Much less so.
Yeah.
The models showed weaker correlations. They didn't seem as influenced by the number of turns as the humans were.
Okay, putting this all together then. What are the big takeaways? What does this mean for people building or using these tools in healthcare?
Well, first, it really points to this idea of LLM brittleness to non-clinical cues. Remember the gender and style changes?
Yeah, LLMs reacted more than humans?
Right. Human recommendations stayed pretty stable, but the LLMs showed measurable shifts. It suggests they have this unwarranted sensitivity to surface-level language features that
Yeah.
humans tend to filter out when making medical judgments.
Which raises those fairness and bias concerns again.
Definitely. If an AI changes its recommendation based on perceived gender or just the tone someone uses, that's introducing variability where it absolutely shouldn't exist.
Okay, so that's the AI side. What about the flip side, the human adaptation to the AI-generated content? That seemed like a really significant finding.
It really was. The fact that human clinicians adjusted their recommendations, more self-management, fewer referrals when dealing with AI-generated summaries or conversations
Mhm.
is, well, it's fascinating and a bit worrying, like you said.
Why did the researchers think that happened?
They proposed two main ideas, and they aren't mutually exclusive. One, maybe the AI content, even if technically accurate, does inadvertently obscure or downplay symptoms in a way that makes humans underestimate the severity.
Okay.
Or two, maybe LLMs are just fundamentally better at interpreting their own outputs than humans are.
The way an AI summarizes might make perfect sense to another AI, but less sense or different sense to a human.
Which tells us a lot about human-AI interaction, not just AI performance.
Precisely. And this study is quite unique because it shifts the focus. It's not just, is the LLM accurate? It's how does human decision-making change when AI is a collaborator?
Especially with those AI conversations mimicking real potential interaction.
Exactly. That's a novel and a really important context to study, moving beyond static text evaluation.
So MedPerturb isn't just a single study, it's more like a toolkit,
Hmm.
a framework. That's the idea. It's designed as this modular, extensible framework. Researchers, developers,
Yeah.
they can use it to probe how models perform under different stresses, understand why humans and AI disagree, and really stress test these medical LLMs in simulation.
To find these hidden issues, this brittleness or bias, before they get rolled out widely.
That's the goal, to help build more robust, reliable, and ultimately more equitable AI systems for healthcare.
This has been incredibly insightful. Let's try and recap that core tension one last time. We've got these powerful LLMs coming into medicine, showing huge promise.
Right.
But their reactions to subtle, non-clinical things, language style, gender cues, how information is formatted, are often quite different from how experienced human clinicians react.
And particularly when the information itself is AI generated, humans seem to react very differently than the AIs do.
The unseen influence there feels critical. As AI gets woven deeper into our lives, especially in really high-stakes areas like medicine, its impact isn't just about getting the right answer anymore.
No, it's about how its outputs subtly, sometimes significantly change human judgment, how it shapes our perception and our decisions.
Which leaves us, and you listening, with a pretty provocative final thought to chew on. If we humans are actually more susceptible to the format and style of AI-generated clinical information than the AIs themselves are, what does that truly imply for the future of human-AI collaboration and critical decisions?
Yeah, how do we make sure that the convenience, the efficiency of AI doesn't inadvertently lead us to be less thorough or introduce biases we don't even consciously recognize?
What does it really mean to be well-informed when the information itself might be subtly shaped by algorithmic tendencies we can't easily see? Something to ponder.